Our last speaker is Dr. Ploenchan Chetchotisakd. She is a professor of medicine, Division of Infectious Disease, Department of Medicine, Khon University. She has been involved in caring of HIV-infected patients in Thailand since the beginning of the epidemic. She is one of the Thai Society committee who developed Thai TB at the Thai ART guideline. So today she is gonna update management of prevention and treating cryptococcal disease. Please welcome Dr. Ploenchan.
Thank you very much for your kind introduction, and thank you, the organizing committee, for inviting me to talk about the cryptococcal disease, which is different from the previous speakers. Cryptococcal disease is still the problem. There are over 100,000 cases cryptococcal disease in the world, but mostly in Africa. However, in Thailand and also in the Asia region, I think it's still the problem, because in Thailand it is the third most common opportunistic infection. My outline today will be on the prevention of cryptococcosis, treatment of cryptococcal meningitis, and for antifungal treatment or adjuvant treatment. And the last one is the timing of antiretroviral treatment. For prevention of cryptococcosis, you can see here, this is a Khon database study show that cryptococcal disease in primary prophylaxis. All of the studies show that given fluconazole or other antifungal can prevent cryptococcosis. However, for the all-cause mortality, you can see here, there is no benefit on the mortality. So the WHO guideline, what they recommend on the prevention of cryptococcal disease, they said that in the patient who have the CD4 less than 100 cells, should screening for cryptococcal antigen prior to antiretroviral treatment. So we emphasize on the screening of the disease other than prevention. And if it's screening positive, after you ruling out cryptococcal meningitis, you should give the patient preemptive antifungal therapy, fluconazole 800 milligrams per day, and then followed by consolidation and maintenance treatment. This approach is preferred over fluconazole primary prophylaxis. However, if the setting that limited of cryptococcal antigen testing and delay in the result of the cryptococcal antigen result, fluconazole should be made available. So this is a message from the guideline of the cryptococcosis. For the treatment of cryptococcosis, several years ago, you also know about this study, the treatment of cryptococcal meningitis into almost 300 cases. They randomized to 3 arms, amphotericin B, 101 milligram per kilo alone, amphotericin B with 5-full-cytosine, and amphotericin B with fluconazole 800 milligram. From this study, the primary outcome is day 14 and day 70 in the mortality rate. You can see here, this is the number of death in this. This is the probability of the survival. There was no significant among 3 arms. However, in the day 70, when they compare group 1 amphotericin B alone with amphotericin B with full cytosine, there is statistical significance. You can see from this Kaplan-Meier curve, amphotericin B with full cytosine did the best, and amphotericin B is the worst, and amphotericin B plus fluconazole is in between. And if you look at the fungal clearance in these three groups, when you compare group 1 amphotericin B alone with amphotericin B with full cytosine has higher fungal clearance and also significant between amphotericin B with fluconazole also. So you know that the treatment, the standard treatment is amphotericin B with full cytosine for 2 weeks. That is the induction. However, with this study, the antifungal combination for treatment of cryptococcal meningitis in Africa, or ACTA trial, that published in 2018, they randomized the patient into the three major groups. The first one is the oral regimen, 2 weeks of fluconazole, 1,200 milligram plus full cytosine, 100 milligram per kilo per day. And then the second group is the 1 week of amphotericin B. And the third group is the 2 weeks of amphotericin B. And in the amphotericin B, they also further randomized to receive 5 FC of full cytosine or fluconazole. So there is a total of 5 arms. In the patient who received 1 week of amphotericin B followed by fluconazole 1,200 milligram for 1 week. This is the largest randomized control trial of cryptococcal meningitis that done before. The patient received consolidation treatment with fluconazole 800 milligram and maintenance with 200 milligram of fluconazole. The ART start at the week 4. This is the mortality rate among the 3 groups. You can see that they are comparable in the 3 arms. So no statistical significance between the 3 arms. But if you divide it into the 5 arms, you can see here that amphotericin B with plus full cytosine for 1 week has the lowest mortality, and then followed by the fluconazole with full cytosine, the oral regimen. When you compare full cytosine and fluconazole group, you can see that mortality rate is higher in the fluconazole group as compared to full cytosine. And in this study, the side effect is less in the oral regimen, especially anemia. And in the 1 week amphotericin B, anemia also less than the 2 weeks. And you know, the patient admit into the hospital just only 1 week, so it's more easy to take care of the patient, okay? Now we look at the, we know that liposomal amphotericin B also effective for the treatment. This is a randomized control trial in 267 patients. They are randomized to 3 arms. The first arm, the first group is amphotericin B deoxycholate, 0.7 milligram per day alone. And the second group is liposomal amphotericin B with the low dose, standard dose, 3 milligram per kilo, and the high dose, 6 milligram per kilo. You can see here the clinical success at week 2 and week 10. They are comparable, no significant difference between the 3 arms. And the survival rate also the same. So in this study, we show that it's not necessary to use the higher dose of liposomal amphotericin B. And as you expected, the infusion-related reaction is more common in the amphotericin B deoxycholate as compared to these two arms. So we know that liposomal amphotericin B can be used at the standard dose. Now we look at any other new strategy of using of liposomal amphotericin B. Last year, there is a phase 2 randomized control trial to look at the short course of high-dose liposomal amphotericin B. So HIV patients with cryptococcal meningitis receive fluconazole for 14 days, randomized to receive either standard liposomal amphotericin B 3 milligrams per kilo per day for 2 weeks. And then high dose of liposomal amphotericin B 10 milligrams per kilo, but given just only single dose on day 1. And the third group is the liposomal amphotericin B 10 milligrams per kilo on day 1 and 5 milligrams per kilo on day 3, 2 doses. And the last one is 10 milligrams on day 1 and 5 milligrams per kilo on day 3 and day 7, so 3 doses. Since it is just only the phase 2 study, they look at the CSF sterilization. You can see from here there is no difference among these studies in each arm. So they choose the single dose 10 milligrams per kilo per day, single dose into the phase 3 study. So we have to wait for this result. It might be easier because you give the patient just only 1 day. Now, I'd like to ask you, from the study that I show you, what is the 2018 WHO recommended induction treatment for cryptococcal meningitis? A is amphotericin B alone for 2 weeks, B ampho with full cytosine for 2 weeks, C amphotericin B with fluconazole for 2 weeks, D amphotericin B with full cytosine just 1 week followed by fluconazole, and E fluconazole high dose with full cytosine for 2 weeks. Please vote. Okay, there is the most common one is the D, and followed by B. B is ampho with full cytosine for 2 weeks. Okay, so this is the WHO guideline for the treatment. Just only 1 week of amphotericin B deoxycholate, 1 milligram per kilo per day with full cytosine, and then followed by fluconazole, 1200 milligram per day. An alternative option is 2 weeks of fluconazole high dose with full cytosine, or 2 weeks of amphotericin B with fluconazole. Okay. For the consolidation treatment is fluconazole 800 milligram for adult. For maintenance treatment is fluconazole 200 milligram per kilo. No, not per kilo, per day. This is a summary of the preferred regimen of the WHO. First week, amphotericin B with 5 FC of full cytosine, and then second week with the high dose of fluconazole, and then followed by consolidation, 800 milligram, and then maintenance treatment until the patient adhere to antiretroviral and virus suppressed CD4 over 100. You can stop the maintenance treatment. And alternative is full cytosine with high dose fluconazole or amphotericin B with high dose fluconazole. You can see that in these induction, they use the high dose of fluconazole. Now, we go to the CDC or IDSA recommendation for induction of cryptococcal meningitis. What is the recommendation? A, amphotericin B with full cytosine for 2 weeks. B, liposomal amphotericin B 3 milligram per kilo with full cytosine. C is the 5 milligram per kilo with full cytosine. D is A and B. E is A and C. Please vote. Okay, so you mostly get the D answer. This is the CDC IDSA guideline. Liposomal amphotericin B 3 to 4 milligram per kilo plus full cytosine 25, but QID, that is 100 milligram per day, the same dose. And you can choose the amphotericin B deoxycholate 0.7 to 1 milligram per kilo plus full cytosine. So there are 2 options for induction in CDC and IDSA guideline. This is an alternative regimen for CDC. There are many amphotericin B high dose or liposomal amphotericin B with fluconazole, ampho B deoxycholate plus fluconazole. But you can see that here the dose is just only 800 milligram. Liposomal amphotericin B alone, amphotericin B deoxycholate alone, or fluconazole, just 400 milligram daily with full cytosine, and fluconazole 800 milligram per day. If you look at the consolidation phase, the fluconazole is only 400 milligram. So this is different from the WHO guideline, okay? And also have an alternative regimen, itraconazole, 200 milligram BID. And maintenance is the same, fluconazole 200 milligram per day. Now we look at the adjuvant therapy of cryptococcal meningitis. This study randomized the patient with HIV positive with cryptococcal meningitis from Asia and Africa, 451 cases, to receive adjuvant therapy with dexamethasone for 6 weeks. They have a tapering dose for 6 weeks and receive placebo. Primary outcome of this study is 10-week survival in intention to treat, and the secondary outcome is survival in 6 months, and disability at 10 weeks and 6 months, and the decrease of cryptococcal count in the CSF, and change in the CSF pressure. In this study, the primary outcome, death or mortality, you can see here, dexamethasone 47% as compared to 41%. There is no statistical significance. However, if you look at disability at week 10, For the good outcome, placebo did better than dexamethasone. And also the CSF clearance of the fungus is lower in dexamethasone group, statistical significant. So this is a Kaplan-Meier curve. You can see that placebo did better, but it's not statistical significant. If you look at the adverse event, you can see here, infection or infestation is more common in dexamethasone group. Gastrointestinal disorder is more common. Renal or urinary disorder also more common. Cardiac disorder also more common. For adjuvant use of steroid is not recommended, okay? For another adjuvant therapy, sertraline, which is an antidepressant, in the in vitro study and also phase 2 show the promising data that sertraline might be adjuvant therapy to the cryptococcal meningitis. So they did the phase 3 study in HIV-positive patients with cryptococcal meningitis. They randomized to receive sertraline or placebo arm. And you can see this is a dose of sertraline. The primary outcome is the 18-week survival in intention to treat, and secondary outcome is the cryptococcal clearance in the CSF. They plan to enroll 550 participants. However, at this point, the trial was stopped for futility because there is no significant difference in the mortality between the two arms. And also the secondary outcome, there is no significant difference in, there is a lower crypto iris 3% and 6%, but this is not statistical significant. The last one is about the timing of antiretroviral treatment in cryptococcal meningitis. This study randomized patients who are cryptococcal meningitis for the first episode. They entry into the study between 7 to 11 days after receive initial antifungal therapy. They randomized to two groups. The early initiation start antiretroviral within 48 hours after study entry before discharge, and the defer arm is wait until the 4 weeks after study entry, after the hospital discharge. From this study, you can see here the defer arm has better survival than the early antiretroviral treatment. So this is different from other opportunistic infection like TB or PCP or other opportunistic infection. You have to treat the patient early after you treat opportunistic infection. But for cryptococcal meningitis, you have to wait until 4 to 6 weeks. And this also for all patients and the 6-month mortality, all prefer defer ART. And this is timing for antiretroviral initiation. Immediate is not recommended, should be deferred until 4 to 6 weeks. Okay, thank you very much for your attention.
Thank you very much, Dr. Ploenchan. Any questions or comments? Okay, we have one question over there.
Hi, I'm Dr. Lin from Myanmar. So I've always confused about the duration of the preemptive antifungal treatment of these patients. So as WHO stated that it is the same with cryptococcal meningitis treatment. So that's at least 1 year. So 2 weeks of induction, 8 weeks of consolidation, and at least 1 year of maintenance. So I personally feel that this regimen is very difficult to convince the clinicians as well as the patient to complete such a long course of therapy. So I would like to know that in your center, do you practice this WHO guideline? And if so, I would like to know what percentage of patients they can complete this long preemptive therapy. That is my first question. And second is that the whole day today, we have seen that for the TB preventive therapy, we are moving to the shorter courses. So likewise, in this cryptococcal field, is there any prospect of any shorter preemptive therapy ongoing as new studies? Thank you.
Okay, the first one, I think in our setting, we also follow the WHO guideline. But as you say, that might be difficult for some patients, but we try to persuade them that this is a serious infection. If you do not treat properly, you might get the cryptococcal meningitis. Okay. For the second, I didn't see any preemptive, shorter duration of the preemptive treatment for this group of patients.
Okay, thank you, Dr. Ploenchan, for your excellent talk.